Okay, so based on introduction, hepatic eye disease is the most common infectious cause of corneal blindness in the developed countries. As many as 60% of corneal ulcers in developing countries may be the result of herpes simplex virus, and about 10 million people worldwide may have hepatic eye disease. The simple virology of the herpes simplex virus is that it is an envelope with a cuboidal capsule, and it has a linear double-stranded DNA genome. There are two subtypes, which is a herpes simplex virus 1 and herpes simplex virus 2, and they reside in almost all neuronal ganglia. The herpes simplex virus 1 causes infection above the waist, principally in the face, in the lips, as in herpes labialis, and also in the eye, whereas the herpes simplex 2 causes generally acquired infection, most times the genital herpes. Rarely, herpes simplex 2 may be transmitted to the eye through infectious secretions by direct inoculation, or through congenitally through as the baby is passing through the birth canal. The herpes simplex virus transmission is facilitated in conditions of crowding and poor hygiene. And since we're discussing herpes simplex virus and its manifestation on the cornea, it is noteworthy that we should also talk a little about what the cornea is and the possible layers of the cornea that are easily affected with herpes simplex virus. The cornea is a complex structure which as well as having a protective role, is responsible for about 3/4 of the optical power of the eye. The cornea is free of blood vessels and is the most densely innervated tissue in the body, with a subepithelial and deeper stromal plexus. It is supplied by the first division of the fifth cranial nerve. For this reason, corneal abrasions and disease processes such as bullous keratopathy are associated with severe pain, photophobia, and reflex lacrimation. The cornea consists of the following layers: the epithelium, the Bowman layer, the stroma, the descemet membrane, and the endothelium. Herpes simplex keratitis is most of transmission. Herpes simplex 1 is acquired by kissing or coming in close contact with a patient suffering from herpes labialis. And herpes simplex 2 infection is transmitted to the eye of neonates through infected genitalia of the mother, as I earlier mentioned. Ocular involvement of herpes simplex virus can be subclassified into two. It will be due to primary infection with the virus or due to recurrent disease. And the features or the clinical signs and symptoms that can be seen during primary infection could be vesicular skin eruption, blepharitis, conjunctivitis, which is usually a follicular conjunctivitis. Then in the cornea, there could be presence of fine epithelial punctate keratitis, coarse epithelial punctate keratitis, and occasionally dendritic ulcer in the primary infection. The recurrent herpes virus ocular disease, it can be subclassified into epithelial keratitis, which could be in the form of punctate epithelial keratitis, or dendritic ulcer, or even geographical ulcer, or it could be in the form of stromal keratitis, in which case it will be a Disciform Keratitis or a necrotizing stromal keratitis. It can also present as trophic keratitis in the form of metahepatic keratitis, or also hepatic iridocyclitis. The primary infection usually occurs without previous viral exposure, so usually occurs in childhood and is spread by droplet transmission, or less frequently by direct inoculation. Due to the protection bestowed by maternal antibodies, it's usually uncommon to have the primary infection is uncommon within the first 6 months of life, though occasionally severe neonatal systemic disease may occur. Most primary infections are subclinical and only cause mild disease such as fever, malaria, and upper respiratory tract symptoms. And the recurrent disease, it occurs due to reactivation of the virus, which is usually latent in the sensory ganglia of most nerve. And after primary infection, the virus is carried to the sensory ganglion for that dermaton, e.g., the trigeminal ganglion, with respect to the affectation to the eye, where it is latent there and is established. The latent virus is incorporated into the host DNA and cannot be eradicated. So once infected with herpes simplex virus, there's a latent infection that remains dormant for life and cannot be eradicated even by antiviral therapy because it's already incorporated into the host DNA. And there could be subclinical reactivation periodically. In subclinical reactivation, the virus is now shed and the person is infectious and can transmit the others to others, but the person does not manifest with any sign and symptoms of the herpes virus. Then there could be clinical reactivation. There's some reactivation, there is viral shedding, as well as symptoms and signs of ocular manifestation to herpes simplex. And there are a variety of stressors that can lead to clinical reactivation, such as in the form of such as fever, or there's a hormonal change, or ultraviolet radiation, trauma, or even injuries to the trigeminal nerve. It can cause clinical reactivation. And when the virus replicates and is transported in the central axons to the periphery, now, commonly the trigeminal branch is affected is the ophthalmic branch of trigeminal nerve that has that presents with most of the ocular features as we will see very soon. The pattern of the disease depends on the site of reactivation, which may be remote from the site of primary disease. Hundreds of reactivation can occur during a lifetime. The rate of ocular recurrence after one episode is about 10% at 1 year and 50% at 10 years. So once the person has had a reactivation once, or a recurrence of the disease once, the chances that it will happen in a year is 10%, and the chances that it can happen in 10 years, 50% chance that it will happen in 10 years. So the higher the number of previous attacks, the greater the risk of recurrence. Risk factors for severe disease, which may be frequently recurrent, include atopic eye disease, childhood immunodeficiency or suppression, malnutrition, measles, and malaria. Inappropriate use of topical steroid may enhance the development of geographic ulceration. So to go a little bit detail on the presentation, we want to take the epithelial keratitis, in which is one of the manifestations of herpes simplex keratitis. It usually presents with symptoms of redness, pain, photophobia, tearing, and decreased vision. The signs can be subclassified based on the kind of epithelial ulcer they can epithelial defect they can create on the cornea. It could be punctate epithelial keratitis, which could be fine punctate or a coarse punctate epithelial defect. It could be dendritic ulcer or a geographical ulcer. The punctate epithelial keratitis, the initial epithelial lesions of recurrent herpes resemble those seen in primary herpes and may be either in the form of fine or coarse superficial lesions, as I had mentioned earlier. In dendritic ulcer, the ulcer is a typical lesion of recurrent epithelial keratitis. The ulcer is of an irregular zigzag linear and branching shape. The branches are generally knobbed at the end, and it's very important that this feature should be noted, as it's one of the features that help to differentiate the dendritic ulcer from herpes simplex virus, from dendritic ulcer from other causes such as varicella zoster or even occasional adenovirus ulcers. The ulcer in the ulcer is knobbed at the periphery in herpes simplex virus. The flow of the ulcer stems with fluorescein, and the virus-laden cells at the margin take over as Bengal. There is an associated marked diminution of corneal sensations. So this is actually a picture that shows the dendritic ulcer on the cornea, and the first one is this one is a ulcer that take up a fluorescein dye, and it's more at the base of the ulcer base, and these are the knob that I earlier mentioned. However, this one is a dendritic ulcer that is stained with rust banga, and if we notice, you can see that the base is poorly stained. However, the edges and the periphery that are laden with the herpes simplex virus are the one, and has a lot of necrotic or dead tissues are the one that is taken up by the rust banga stain. And also this is a picture to illustrate the herpes simplex and the dendritic ulcer on the cornea here. This is with fluorescein staining, and this one is just the picture prior to staining. Okay, this is dendritic ulcer. The knob or the ulcer has coalesced and expand to engulf a large portion of the cornea, and in this situation, it is a geographical ulcer. So as I mentioned, sometimes the branches of the dendritic ulcer enlarge and coalesce to form a large epithelial ulcer, which is geographical or amoeboid in configuration, hence the name geographical ulcer. The use of steroid in the dendritic ulcer hastens the formation of geographical ulcer. So in this situation, steroid is as well prohibited or contraindicated in epithelial defects of herpes virus. The differential diagnosis of herpes dendritic ulcer could be a dendritic ulcer from herpes zoster keratitis. It could be a healing corneal abrasion. Maybe there was an abrasion for whatever mechanical corneal abrasion, and it's healing. It looks like a corneal. It also looks like a dendrite. In that case, we call it a pseudodendrite. In the form of amoebic keratitis, also, it's a feature. It is a differential diagnosis of dendritic ulcer. Epithelial rejection in the corneal graft also can present like this. The use of soft contact lenses can present like this. Then toxic keratopathies occurring with topical medications could also look like this. So how do we, as we have seen the clinical features and the signs, which could help in our diagnosis, of which the diagnosis is mostly clinical, investigation can also assist in the diagnosis. So a pre-treatment scraping can be done, and it should be sent in a viral transport medium for culture. That scraping can also be used for PCR and immunocytochemistry where available and also to help in the diagnosis of herpes, where the herpes virus can be seen. The DNA of the herpes virus can be elucidated. Also, giemsa staining is important in situations where, in facilities where we don't have a viral culture medium or PCR or immunocytochemistry, we can do a giemsa staining in which the presence of multinucleated giant cells can be helpful to suggest herpes simplex virus infection of the cornea. Herpes simplex virus serological titer can also be done, and it is it's raised more in primary infection. So how do we treat? It's important that I bring treatment here because the treatment of the virus manifestation of herpes simplex keratitis, it could be a little bit different. So as I discussed a dendritic ulceration, I will just discuss its treatment and move to the other presentation of herpes simplex keratitis. So majority of the dendritic ulcers heal spontaneously without treatment. The treatment of herpes simplex virus disease is predominantly with the nucleoside analogs that disrupt the viral DNA. And the commonly used topical antiviral agents as I mentioned here. Commonly available to us is the 3% acyclovir ointment, which is commonly used for 5 times a day. Other ones available is trifluoridine, which is a 1%, which is used. Some books says 4 times a day. Some said 8 times a day. Idozuridine 5% drop can also be used 5 times a day. Vidarabine and ganciclovir can also be used. This is depending on whether they are available in the set environment. And it's also worthy to know that though there could be some relative toxicity of the antivirals to the epithelium, but it's relatively safe to use for up to 6 days. And the good news is that most of these epithelial defects will heal within 2 weeks. So application of this topical antiviral could be for 10 to 14 days, and the ulcer could heal. And it is important that another treatment modality is debridement, and is may be used for resistant cases, and it helps to remove the virus-containing cells, because at the edges, you debride the edges and up to 2 millimeters after the edge of the wound. So it takes off, as I rightly mentioned, that the virus may be more in the periphery, and so debriding reduce the viral load and hence help in the healing. A topical antiviral agent should also be used while in conjunction with the debriding. Oral antiviral therapy is also advocated for patients. You can use acyclovir 200 to 400 milligrams 5 times a day for 5 to 10 days. Cyclophagia is also important cyclophagics are also important so that can help to improve the comfort of the patient. Topical antibiotics can be given as prophylaxis since there could be other microbial co-infection occurring with the herpes simplex keratitis. Skin lesions such as vesicles that are seen in the periocular skin and the lid margin can also be treated. Can be treated with an acyclovir cream, which is usually applied 5 times a day too. In the case of slow healing or frequent recurrence, it may indicate the presence of resistant viral strain. So in that case, an alternative topical agent may be necessary, or also debridement, as I had mentioned, may be tried. In especially refractive cases, a combination of 2 topical agents with oral acyclovir or famciclovir may be effective. A significant minority of resistant cases are due to varicella zoster virus. So in the case that you're treating, you have changed medication, you have done what is necessary, and the ulcer is still refractory, the chances that the infection may not just be from herpes simplex virus is high. We should now consider other differentials that can give dendritic ulcer, such as varicella zoster virus. And the stromal presentation, there could be stromal affectation of the cornea, which one of the presentation is in the form of Disciform Keratitis. And they say the HO pathogenesis is controversial. However, it is thought that there is an active infection of the keratocytes or the endothelium, or there is a delayed hypersensitivity reaction to the viral antigen in the cornea. So that is the HO pathogenesis postulated that leads to Disciform Keratitis. The symptoms, the symptoms include blurred vision, hair loss, discomfort, and redness. It tends to be milder than a purely epithelial disease. The signs include stromal epithelial edema. There could also be a reactive anterior chamber, and also the presence of keratic precipitates, mostly granulomatous type underlying the edema. You could also present with faults in the descemet membrane, and there could also be a surrounding Wesley ring this stroma has. A Western ring is like a round deposit on the cornea, and it is due to the deposit of the viral antigen or immune complexes of the virus and the immunoglobulins deposited on the cornea, and it is in a ring pattern on the cornea. Because of the involvement of the anterior chamber and possible trabeculitis that could occur, the IOP may be elevated. There's reduced corneal sensations. There is mid-stroma scarring. The differential diagnosis of Disciform Keratitis includes keratitis from acanthamoeba and fungal keratitis. Now, these are some of the images I have to show. This shows an epithelial and stromal edema and the presence of descemet folds. The presence of descemet folds in the cornea. This is the Wesley ring, as I had made mention, which is due to the position of viral antigens and immune complexes, and gives a ring-like configuration. These are keratic precipitates that are seen on the cornea, and is scarring of the stroma and vascularization as demonstrated in this picture. So the treatment is usually tailored individually. There's an initial treatment with topical steroids, 1% prednisolone or 0.1% dexamethasone, and with antiviral copper, both 4 times daily. The oral steroids are sometimes used in severe stroma infiltration as an adjunct, or to reduce the steroid-induced IOP elevation. Sometimes in steroid responders, there could be a marked elevation in the IOP. So in that situation, it is safer to either to titrate or reduce the topical steroid, and now include an oral steroid, as the effect of the oral steroid is less on IOP compared to topical steroid. Topical cyclosporin 0.05% may be useful, particularly in the presence of epithelial ulceration, to facilitate tapering of the topical steroid as a steroid-related IOP elevation. So in complications such as steroid-related complications, cyclosporin can be also included in the treatment. Fine needle diatemy and laser techniques have been reported as successfully addressing established corneal neovascularization and improving vision. The other stromal manifestation of herpes simplex virus is the necrotizing stromal keratitis. This rare condition is thought to result from active viral replication within the stroma, though immune-mediated inflammation is likely to play a significant role also. It may be difficult to distinguish from severe disform keratitis, and there may be a spectrum of disease, including an overlap with neurotrophic keratopathy, as with Disciform Keratitis. A similar clinical picture may be caused by other infections. Clinical features in necrotizing stromal keratitis include stroma necrosis and melting. Is usually profound with interstitial opacification. There could be anterior uveitis with the presence of keratic precipitates, as it occurs also in Disciform Keratitis. An epithelial defect may be present in this case. The progression to scarring vascularization, you will now progress to scarring vascularization and lipid deposition on the cornea. The treatment is broadly similar to that of aggressive Disciform Keratitis, but oral antiviral supplementation initially at the upper end of the dose range is commonly used. So as we meant in necrotizing stromal keratitis, there will be need for an oral antiviral agent and at a higher dose. The restoration of epithelial integrity is critical. So this picture here is an image to show the necrotizing stromal keratitis due to herpes simplex virus. So the indications for use of systemic acyclovir is in non-responsive immune-compromised primary herpes simplex infected case, especially with iridocyclitis, it's important to use a systemic antiviral agent to help in reducing the viral load in the body. Then significant primary herpes simplex infection, infectious epithelial keratitis in adults, and a recurrent epithelial infection. So it does is 200 to 400 milligrams twice daily for as long as 6 months, or even much more to a year or so, because of it helps to reduce the rate of recurrence in the patient. Now, when the patient is due to the complications such as scarring and corneal perforation, before planning for penetrating keratoplasty, it's good to give systemic acyclovir, as it is said to reduce the viral load and prevent the risks of reactivation, even in the new graft and also graft failure. So this slide is to just mention quite a number of complications that can also occur due to herpes simplex virus keratitis. Is neurotrophic keratopathy can occur, and it's due to, because of the reduced corneal sensation, ulcers, the corneal hypoesthesia, the ulcers do not heal well, and the cornea is susceptible to other form of trauma or infections that could worsen the ulceration caused by the herpes simplex virus. Iridocyclitis, as I mentioned, is a complication, and with resultant iris atrophy. There could be secondary microbial infection. As we know, most of the bacteria could not penetrate an intact corneal epithelium. Now, with an infection with herpes simplex virus, there is a corneal defect, so it becomes easier for many other microorganisms, bacteria, to now gain entry and cause severe infection of the cornea, hence worsening or complicating the herpes simplex virus infection. There could be secondary glaucoma, which could be due to primarily due to the trabeculitis, or secondarily due to the steroid used in treatment of stroma-related herpes simplex virus keratitis. Corneal blindness from corneal perforation, scarring, and vascularization could also be a complication. And persistent corneal epithelial defect, also anterior uveitis, metahepatic keratitis, which is a presentation also of the herpes simplex virus. And there could be wall epithelial defect, and this is due to assiduous and prolonged antiviral application. And this wall epithelial defect can also be used actually for monitoring, as in it can, in a patient that claim to be using topical antiviral for a long time without this wall epithelial defect, it makes you to suspect poor compliance, because for a prolonged use of the antiviral, topical antiviral agent, it gives a wall epithelial defect like this. And there could be allergy to the medications. There could be cataract due to involvement of the iris, and also due to use of steroids. And because most of the antiviral we have are in the form of ointment, there could be punctal occlusion from the ointment, and so I list it as a complication of herpes simplex, a secondary complication. So other adjuvant therapy that can be used in herpes simplex keratitis depend on the extent of the disease. So in a patient that has some form of has a corneal perforation or an impending corneal perforation, actually, the need to use a therapeutic contact lens would be important. And for patients with progressive corneal melting, they need to give also collagenase inhibitors, commonly used as tetracycline and doxycycline in our environment, would be also important. Some of those patients, because of the skin lesions, the periocular skin lesions, there could be lid retraction, and the chances of also exposure keratopathy could be there. So the patients may require tassorrhaphy, depending on the severity, as I mentioned. Conjunctival flap can be also used. Now, in an impending corneal perforation or perforated corneal ulcer, there may be need for use of cyanoacrylate glue. Then finally, with loss of vision, corneal blindness, secondary to scarring, vascularization, and lipid deposition, the patient may benefit from lamellar or penetrating keratoplasty. In conclusion, herpes simplex virus is the cause of a multisystemic disease with mild to severe ocular manifestation. Good knowledge of its etiopathogenesis is relevant to the ophthalmologist for proper diagnosis and management of its features and complications. Thank you. This is my bibliography. Thank you very much.